The phone call started like any other. It was a Tuesday afternoon, and Mark was on his way home from work, navigating the familiar rhythm of traffic. He called his mother, Eleanor, every other day. It was their ritual, a small anchor of connection in a busy week. For 82 years, Eleanor had been a rock, sharp, organized, fiercely independent. Her voice on the other end of the line was usually the most predictable part of his day. But not this time. She sounded thin. Not physically weak, but as if her usual confidence had been stretched taut, almost to the breaking point. After a few minutes of small talk, she brought up the mail. "Mark, I'm worried about the electricity bill," she said, her voice tight. "It hasn't come. It's always here by the 5th of the month." Mark smiled to himself. He'd been to her house that past weekend and had sorted her mail for her. "Mom, it's okay. I saw it on the kitchen counter. Remember? We put it in the folder for bills to be paid." There was a pause. Not a pause of recollection, but a pause of resistance. "No," she said, her voice a little sharper now. "No, that was the water bill. The electricity bill is missing. I think someone might have taken it from the mailbox." This was new. Mark's hand tightened on the steering wheel. His mother wasn't a paranoid person. He tried to gently reason with her. "Mom, I'm certain it was there. It was the white envelope with the blue logo. I opened it for you. It's due on the 20th. "I don't know, Mark. I just have this feeling. I've been up all night thinking about it." And there it was, the second detail. "You didn't sleep well again?" he asked, a familiar question over the last few weeks. She sighed, a sound of weary resignation. "Oh, I just don't sleep like I used to. I'm up and down, up and down. It's just part of getting old, I suppose." Mark felt that flicker of unease, a tiny, cold spark in his gut. It was the same flicker he'd felt last week when she'd called him, convinced she'd lost her favorite pair of glasses, only to find them on top of her head. Each incident on its own was nothing. A forgotten bill. A misplaced item. A poor night's sleep. These were the mundane frustrations of aging, things his friends all talked about with their own parents. It was so easy to brush them aside. It was easier to believe that this was just the new normal. So he did what any loving son would do. He reassured her. He promised to come by the next day and show her the bill, safe in its folder. He told her to try and take a nap. He ended the call, and for a few minutes he felt better. He had calmed her down. He had solved the problem. But he hadn't solved the problem. He had only addressed the symptom. He didn't know it then, but that phone call wasn't about a missing bill. It wasn't about a bad night's sleep. He was witnessing the first subtle signs of a gathering storm that was forming not in his mother's body, but in her brain. And in ignoring that quiet warning, he was walking, completely unaware, toward a devastating and preventable crisis. I'm Dr. Dane. That subtle, unsettling conversation is a scene I've heard described countless times by families. It's that quiet moment of unease when the person you know better than anyone in the world starts to feel like a stranger in their own mind, even for a second. It's a feeling of dissonance, a small crack in the foundation of what you thought was solid ground. Families sense it. They feel it in their gut, long before any medical test can measure it. They are witnessing the earliest tremors of a medical earthquake, but no one has given them the seismic map. They're told it's just getting older or stress or a momentary lapse. The system, with all its good intentions, is focused on the big, obvious fractures. The broken hip, the pneumonia, the heart attack. It isn't built to register these faint vibrations that precede the main shock. It doesn't have a language for the quiet anxiety over a non-existent bill. My mission on this channel is to give you that map. It's to translate the language of those subtle warnings. We look at the evidence, not to create fear, but to build competence. We sift through the clinical studies and the institutional guidelines to find the practical knowledge that can change an outcome. The goal is to empower you, to help you navigate the complex world of healthcare, not just as a patient or a worried family member, but as a prepared, knowledgeable advocate for your own quality of life or the quality of life of someone you love. This isn't about rejecting medicine. It's about engaging with it more intelligently. It's about knowing which questions to ask, which signs to watch for, and when to raise your hand and say, wait, I'm concerned about this. Because the power to prevent a crisis often lies in seeing the full picture before anyone else has even started to look. And to see that picture clearly, you have to start with a truth the medical system isn't built to tell you. When a person over the age of 70 is admitted to the hospital, the single greatest danger they face is often not the illness they came in with. It's not the pneumonia, it's not the broken hip, and it's not the heart failure. Those are the problems we know how to fix. The greatest danger is a sudden, terrifying, and acute state of confusion called delirium. It's like a switch flips in the brain. The person you know, your mother, your father, your partner, is suddenly gone. They can become intensely agitated, paranoid, seeing things that aren't there. Or they can swing to the other extreme, becoming so lethargic and unresponsive it's hard to even wake them. And because this sudden change looks so much like a catastrophic cognitive decline, it is almost always mislabeled. It's dismissed as a sudden worsening of dementia, or simply the unavoidable confusion of a sick, elderly person. But it is not dementia. And it is not normal. It is an acute medical emergency. It is a sign that the brain is in crisis, overwhelmed and failing under a load of stress it can no longer handle. And here is the most critical piece of this puzzle, the part that is almost universally missed by a system designed for acute intervention. The most important, most preventable phase of delirium doesn't happen under the bright, beeping chaos of an ICU. It doesn't begin when the anesthesia is given for surgery, or when the first dose of a powerful new medication is administered. It begins in the days and sometimes weeks before they ever leave their own home. It starts in those quiet moments of anxiety over a misplaced bill that Mark dismissed. It grows in the long, sleepless nights that Eleanor chalked up to just getting old. This is the period I call the Delirium Shadow. It is the subtle gathering storm. It's the faint, almost invisible evidence that a person's brain is already approaching its breaking point. The illness or the fall that brings them to the hospital isn't the cause of the delirium. It's just the final push over the edge. The hospital doesn't create the vulnerability. It simply, and often brutally, reveals it. And because we aren't trained to see this shadow, we are always one step behind, treating a full-blown crisis instead of preventing it from ever happening. So our goal in this video is to get ahead of that crisis. We are going to pull back the curtain on this hidden epidemic and give you the map that families like Mark's so desperately need. First, we will walk through the 5 subtle pre-hospital signs of the delirium shadow. These are the quiet warnings that the brain is under stress long before the chaos of a hospital stay begins. As we go, I'll share the rest of Mark and Eleanor's story. It's a difficult story, but seeing how quickly this situation can escalate is a lesson in itself, and it provides a real-world context for the evidence we'll discuss. And most importantly, I'm not going to leave you with just the problem. My promise to you is that by the end of this video, you will have a simple, evidence-based toolkit. A set of questions and a framework that will allow you to communicate your concerns effectively, to partner with medical staff, and to advocate for your loved one in a way that can help prevent this devastating cascade. This is about turning that vague, helpless feeling of worry into focused, competent action. And as you'll soon see, some of these signs are so counterintuitive they are almost designed to be misinterpreted, even by doctors. Pay close attention when we get to sign number 3. It involves simple sensory changes, like a complaint about the lights being too bright, or a fleeting comment about a shadow in the corner. It's a sign that hides in plain sight, dismissed as a quirk of old age, but it's often a direct flare from a brain struggling to process reality. Recognizing it changes everything. And you absolutely must stick with me to the end, because the 5th sign reveals a dangerous paradox at the heart of our medical system. It explains how a doctor's completely well-intentioned prescription, a common pill given to help with sleep or anxiety, can accidentally become the primary trigger that ignites the entire devastating cascade of delirium. It's a situation where the intended solution becomes the catalyst for the crisis. These signs aren't abstract theory from a textbook. They are real, lived moments in the lives of families just like Mark's. Before we dive into the 5 signs, I want to ask you something. And this is important because the experience I'm describing is one that so many families go through in silence, convinced they are the only ones. Have you ever been with an older loved one in the hospital and felt that their confusion or their personality seemed to change almost overnight? One moment they are themselves, and the next they seem lost, agitated, or distant, and you're left with a profound and frightening sense of disconnect. You don't need to share any personal details, but just a simple yes in the comments below does something incredibly powerful. It acts as a quiet signal to every other person reading them, a signal that says, you are not alone in this. It transforms a private, often traumatic memory into a shared experience. When you see hundreds of people confirming that they have walked the same path, it becomes clear this isn't a rare or isolated event. It's a pattern. It's a systemic issue that we need to face together. Your one-word comment helps to build that crucial sense of community and shared understanding. It shows the true scale of this problem in a way that no clinical statistic ever could. To understand why this happens, why a mind that seems so stable can be thrown into chaos so quickly, we first need to understand a fundamental principle about the aging brain. It's a concept that explains the invisible line between coping and crisis. I call it the vulnerability threshold. Think of an older brain as a sophisticated but delicate ecosystem. Over decades of life, it builds incredible networks of wisdom and experience, but it also gradually loses some of its resilience. It's like a coastal shoreline that is slowly eroded over time. The natural buffer that once absorbed the storm surge is now thinner, more fragile. The vulnerability threshold is that new, closer shoreline. It's the tipping point where stressors, things that a younger brain would easily absorb, suddenly overwhelm the brain's ability to maintain its equilibrium. These stressors aren't always dramatic. They can be a low-grade infection, a new sleeping pill, a day of not drinking enough water, or a few nights of poor sleep. Individually, they are small waves. But when they hit a system with a reduced buffer, they don't just lap at the shore. They breach the defenses. They flood the entire system, plunging the mind into the functional chaos we call delirium. This threshold is different for every single person, and it's not static. To see how a simple illness interacts with two very different thresholds, let's compare a 30-year-old brain to an 85-year-old brain facing the exact same challenge. A 30-year-old contracts a urinary tract infection. The signs are classic and clear. They develop a fever, they feel unwell, and they have pain. It's uncomfortable, but their brain is never really part of the equation. It has a massive cognitive reserve, a deep well of resilience that easily absorbs the inflammatory stress from the infection. The body's alarm system is loud and specific, directing attention to the problem in the urinary tract. The brain, meanwhile, continues to manage everything else without missing a beat. It has the bandwidth to handle the crisis. Now, let's take an 85-year-old with that exact same urinary tract infection caused by the very same bacteria. Their body's alarm system has changed. They might not mount a strong fever. They may not even complain of significant pain. For them, the first and sometimes the only symptom is confusion. It could be subtle, like Eleanor's anxiety over a bill, or it could be more pronounced. This isn't a psychological reaction to being ill. It is a physiological sign of organ dysfunction. The brain, with its shallower reserve and a vulnerability threshold that is much closer to the surface, is the first system to falter under the inflammatory load. The infection has not changed. The bacteria are the same. But the resilience of the patient has fundamentally shifted. Their brain is now the weakest link in the chain, the most sensitive barometer of their internal well-being. The confusion is the equivalent of the 30-year-old's fever. It is the primary signal that something is wrong. This inherent internal vulnerability is the dry kindling. It explains why a seemingly minor issue can have such profound cognitive effects. But the kindling doesn't burst into flame on its own. It needs a spark. And that spark is often found when we take this person, whose brain is already operating so close to its limit, and place them into an environment that is paradoxically designed for healing, but is also a perfect storm of cognitive stressors. Now, place that person into a hospital bed. Suddenly, the familiar rhythms of home are gone. They're replaced by the steady, high-pitched beep of an IV pump that never stops, a sound that becomes the soundtrack to their anxiety. The gentle darkness of their own bedroom is shattered every 2 hours by a bright overhead light and a stranger asking them to move their arm for a blood pressure cuff. They are in a strange bed, in a strange room, surrounded by the muffled conversations and alarms of a world they don't understand. They might be physically tethered by an IV line, making every small movement a negotiation. A urinary catheter can be profoundly disorienting, a constant source of discomfort and confusion. Every single one of these things is done with the best of intentions. The monitoring's for safety. The IV is for medication. The environment is designed for efficient, acute medical care. But for a brain already hovering at its vulnerability threshold, this environment is a perfect storm. It is a relentless assault of cognitive stressors. It systematically deprives them of the two things a fragile brain needs most: deep, restorative sleep and a sense of familiar orientation. The hospital, in its mission to heal the body, can inadvertently push the brain past its breaking point. And it is the system's well-meaning response to the resulting agitation and confusion that ignites the next and perhaps most dangerous part of this process. This is where a small problem begins its rapid downward slide into a crisis. This is the start of the delirium cascade. It's a term for a well-documented and terrifyingly common downward spiral. It's a slippery slope where each well-intentioned medical response to a symptom inadvertently makes the underlying problem worse, creating a feedback loop that can be incredibly difficult to stop. It's the moment a manageable issue starts to snowball into a crisis. It starts with the initial confusion. Let's go back to our 85-year-old with the silent UTI. Their confusion is noted, but they become agitated because they are disoriented, frightened, and can't make sense of their surroundings. They might try to get out of bed, not understanding they're attached to an IV. In a busy hospital ward, this agitation is often seen not as a physiological symptom of the brain's distress, but as a behavioral problem that needs to be managed for the patient's own safety. So, a sedative is ordered. A small dose of a common anti-anxiety drug, perhaps, to help them rest. But in a brain already operating at its vulnerability threshold, that sedative acts like an extinguisher, smothering the already flickering flames of consciousness. It doesn't calm the agitation in a meaningful way. It deepens the confusion, pushing them further into the fog. Now the patient is even more disoriented, their reality more fractured. They may try to pull out their IV line again, not out of aggression, but out of a primal, panicked need to escape a perceived threat they can no longer articulate. The response, again, is for their own safety. It might be physical restraints. Soft cuffs on the wrists. Now, on top of the internal chaos, there is external terror. They are trapped. The agitation escalates into raw panic. Do you see the pattern? A minor, easily treatable infection has now cascaded, step by logical, protocol-driven step, into a full-blown medical crisis. The initial problem, the UTI, is almost forgotten, replaced by the urgent need to manage an uncooperative patient. The long-term consequences are immense. This isn't just a bad night in the hospital. It's a significantly longer stay, a higher risk of complications like falls and pressure sores, and for a heartbreaking number of patients, a permanent decline in cognitive function that robs them of their independence long after they go home. This entire devastating cascade can often be prevented. The key isn't some high-tech intervention once they're in the ICU. It's in recognizing the very first, almost silent signals the brain sends out weeks before a hospital admission is even on the horizon. And that brings us to the first sign of the delirium shadow, which counterintuitively is almost never about memory or cognition. It's emotional. It's not what you'd expect. It's not memory loss. It's a change in what you might call the brain's emotional thermostat. This is exactly what Mark was hearing in Eleanor's voice: a new or worsening anxiety, an uncharacteristic irritability, or a persistent low-grade restlessness she couldn't explain. She was worried about a bill that wasn't missing. She felt on edge. This emotional shift is almost always paired with a fractured sleep-wake cycle. It's not just about getting fewer hours of sleep, it's about the quality. Waking frequently through the night, struggling to fall back asleep, and then experiencing an unusual heavy drowsiness during the day. It's a profound disruption. The most dangerous thing about this sign is how easily we dismiss it. We've all heard it, or even said it. It's just part of getting old. But this isn't a benign symptom of age. It's a critical distress signal. It's evidence that the brain's regulatory systems are under significant stress from a hidden source, like a silent infection or metabolic imbalance. For Eleanor, this combination of anxiety and poor sleep wasn't just a state of mind. It was a state of being that was about to have devastating physical consequences. A week after that phone call, the storm made landfall. It didn't arrive with a dramatic diagnosis or a sudden collapse. It arrived with a simple, common household accident. Eleanor was in her kitchen, reaching for a mug in the cupboard. Her foot slipped, just for a second. It wasn't a great tumbling fall. It was an awkward, stumbling trip that ended with her on the floor, a searing pain shooting up from her hip. In the controlled chaos of the emergency room, the world shrank to the size of that single fractured bone. X-rays were taken, IV lines were started, and the rhythmic beeps of monitors filled the air. The orthopedic surgeon was paged. A plan was already forming: stabilization, pain management, surgery. The system was doing exactly what it was designed to do. It was addressing the acute mechanical problem with speed and efficiency. Mark stood by her gurney, trying to be the calm center in her storm of pain and fear, but he was also trying to be her historian, her advocate. He remembered the phone call, the anxiety, the sleepless nights. He knew intuitively that these things were connected. When a nurse came to update her chart, he tried to explain. "She hasn't been herself for the last few weeks," he said, his voice low, trying not to add to the noise. "She's been much more anxious than usual. Quite bothered. And she's barely been sleeping." The nurse, competent and kind, but stretched thin between 3 other patients, nodded as she wrote. "That's understandable," she said, her focus on the monitor. "A fall like this is very stressful, and she's in a lot of pain. We're giving her something to help with that now." Mark felt a wave of frustration. He tried again. "No, I mean, this was before the fall. This has been going on for a while. It's not like her." The nurse looked at him, her expression sympathetic, but her eyes revealing the pressure of her other duties. "We'll note that in her chart," she said, and then she was gone, moving on to the next urgent task. It was noted, but it wasn't heard. It was filed away as understandable stress, a predictable emotional response to a physical injury. No one in that room could see the full picture. No one understood that Eleanor's brain had already crossed its vulnerability threshold before her foot ever slipped on the linoleum floor. The sleepless nights and the simmering anxiety weren't a reaction to the fall. They were the subtle signs that her brain's resilience was already depleted. The fall wasn't the start of the problem. It was a symptom of it. A brain under stress from a silent underlying issue, perhaps a low-grade infection, dehydration, or a metabolic change, is a brain that can't manage balance, attention, and executive function as well as it used to. The broken hip was just the loudest, most obvious consequence of a much quieter, deeper crisis that had been brewing for weeks in the Delirium Shadow. The entire medical team was focused, with the best of intentions, on the mechanical fix. They saw a broken bone that needed to be pinned and set. They were mechanics for the body. But no one was acting as the guardian for the brain. No one was connecting the dots between a misplaced bill, a sleepless night, and a fractured femur. And in failing to see that connection, they were about to push Eleanor and her already fragile brain into a cascade that was far more damaging than the break itself. This isn't just Mark and Eleanor's story. It's a textbook case of a pattern that is so well documented, so thoroughly researched, that major medical bodies around the world have published extensive guidelines on how to prevent it. The heartbreaking part is how often that evidence fails to make its way to the bedside, lost in the urgent rush to fix the thing that is most obviously broken. This isn't just an unfortunate story. This is not fringe science. It is established evidence-based medicine. In the United States, the American Geriatric Society, the gold standard for the care of older adults, has published extensive guidelines on identifying these exact risk factors. Their international counterparts, like the highly respected National Institute for Health and Care Excellence, or NICE in the UK, echo the same urgent warnings. These aren't obscure research papers buried in a library. They are the clinical playbooks meant to guide practice at every hospital bedside. And what do these expert consensus guidelines highlight as the biggest red flags? They explicitly list the top predictors for delirium. Things like pre-existing cognitive impairment, sensory issues like poor vision or hearing, and crucially, the very signs that formed Eleanor's delirium shadow: sleep deprivation, immobility, and dehydration. These are the vital signs for brain vulnerability. These guidelines are designed to be a safety net, a formal recognition that a person's mental state and resilience before they enter the hospital is one of the most important predictors of what will happen to them once they are inside. So if the map has already been drawn by the experts, why do so many people fall off the cliff? The answer lies in the rush of acute care. The system is fundamentally biased toward action on hard data. A dangerously low potassium level on a blood test triggers an immediate protocol. A fracture on an X-ray demands an orthopedic consult. These are clear, undeniable problems. But a family member's report that she's been more anxious or she hasn't been sleeping is categorized as a soft sign. It's qualitative, subjective. It's noted in the chart, but it rarely triggers the same level of urgent, system-wide response. It's treated as background noise instead of the primary signal of a brain already in crisis. This gap between established knowledge and daily practice is where the tragedy lies. It's not a minor oversight. This failure to act on the early warnings has a real quantifiable impact, measured not just in healthcare costs, but in lives permanently altered. And when you see the numbers, you begin to understand just how immense the stakes really are. Let's put some hard numbers on this gap between established evidence and what happens at the bedside. Studies published in leading medical journals like the New England Journal of Medicine and JAMA consistently show that between 30 and 40% of delirium cases in the hospital are preventable. Let that sink in. This isn't a small margin of error. It is a massive, systemic failure. For every 10 older adults who suffer through this terrifying ordeal, 3 or 4 of them never had to. They are individuals with families, stories, and futures that were profoundly altered by a preventable cascade. We are not talking about a rare, unavoidable complication. We are talking about one of the most common events in geriatric hospital care, and we often fail to stop it, even when we have the tools to do so. The cost of this failure isn't just measured in the billions of dollars spent on longer hospital stays. The human cost is staggering. A single episode of delirium can act like a fire in the brain, burning away cognitive reserve that may never be recovered. It can permanently accelerate a person's decline into dementia. It is one of the single biggest reasons an older person loses their independence after a hospital stay, trading their own home for the long-term care of an assisted living facility. And the stakes are even higher than that. The evidence is chillingly clear. Delirium is a powerful predictor of mortality. A landmark 2010 study found that experiencing delirium is associated with a 2-fold to 3-fold increased risk of death within the next year. It is a sign that the body and brain are under a level of stress from which they may not be able to recover. It's not just a temporary confusion, it's a fundamental crisis of the entire system. These numbers are frightening. They paint a picture of a medical system that, despite its best efforts, is often blind to the most significant threat its older patients face. But these statistics are not a cause for despair. They are a call to action. That 30 to 40% prevention rate is not just a number on a page, it is an opportunity. It is a window of time where a prepared, informed advocate can step in and change the entire trajectory of care. And the solution doesn't start with a new drug or a high-tech scanner. So how do we close that 40% prevention gap? It starts with you. And it starts not with a confrontation, but with a simple, powerful shift in language. The solution is to change the conversation you have with the medical staff, from one of describing symptoms to one of assessing risk. When Mark told the nurse his mother was anxious and not sleeping, he was describing symptoms. The nurse translated that into a predictable emotional response to pain and stress. The system has a standard, often inadequate response for that. But what if instead he had used a different framework? I am concerned about my mother's risk for delirium. I've noticed for the past 2 weeks she's had significant anxiety and a very disrupted sleep pattern, and I know these are major risk factors. Do you hear the difference? That single sentence changes everything. It uses their language. The word delirium is a specific clinical term that triggers a different set of protocols. The phrase risk factors signals that you are an informed partner, not just a worried bystander. You are no longer just reporting a feeling. You are presenting a concise, evidence-based risk assessment for a specific preventable and dangerous condition. This reframing is your most powerful tool. It elevates the soft signs of anxiety and poor sleep into hard data that a good clinical team cannot ignore. But these emotional disturbances are only one part of the picture. The delirium shadow also casts a subtle effect on cognition itself, a quiet fraying at the edges of their thinking that is even easier for a busy hospital to miss. And that brings us to the second sign of the delirium shadow: subtle cognitive slips. Now, we need to be very careful here because this is where the line gets blurry for many families. It's easy to hear cognitive slips and immediately think of the normal frustrating moments of aging. We all know someone who occasionally forgets a name or misplaces their keys. This is not that. I am not talking about the slow, gradual changes in memory that can happen over many years. What we are looking for is a distinct change from a person's normal baseline. It's a shift in the texture and rhythm of their thinking. This isn't profound confusion yet. It's a new difficulty focusing on a conversation where you can see their attention drifting. It's losing their train of thought mid-sentence, stopping and saying, "Now, what was I talking about?" far more frequently than they used to. It's that frustrating search for a common word that suddenly seems to be happening all the time. They might seem more distractible, easily pulled off topic by a sound from the other room. Or you might notice a subtle dip in their short-term memory, like asking you the same question twice within an hour. For Mark, looking back, he realized his mother had asked him 3 separate times during a single visit if he had remembered to get his car's oil changed. At the time, he thought she was just being a mom. In retrospect, he saw it was a small crack in her usual cognitive function. This is precisely why these signs are so often missed by the medical system. A doctor in a busy emergency room has no way of knowing what a person's baseline is. They see an 82-year-old who seems a bit distracted and slow to respond, and they might conclude that it's simply her age. But you, the family member, you are the true expert on that person's baseline. You know the difference between their normal state and this new, subtle fog? You can detect the change. These slips aren't a sign that memories are being erased, like in dementia. It's something different. They are a sign that the brain's processing power is being consumed by a hidden battle. To truly understand what's happening, it helps to think about the brain not as a library of facts, but as a powerful biological computer. Think of the brain's processing power like the RAM, or random access memory on your computer. When everything is running smoothly, you have plenty of RAM available. You can open multiple programs, browse the web, and switch between tasks seamlessly. The system is responsive and efficient. This is the brain in a state of healthy equilibrium. Now, imagine a hidden stressor, like Eleanor's silent low-grade infection or creeping dehydration, is like a demanding, resource-heavy program running silently in the background. It's not a virus that's corrupting your files, but it's consuming a massive amount of your available RAM. You might not even know it's there, but you can feel its effects on the entire system. The computer still works. It hasn't crashed, but it's slow. It lags. A web page that used to load instantly now takes a few extra seconds. The mouse stutters for a moment. You click on a program and for a beat, nothing happens. The system seems to freeze. These are the subtle cognitive slips. Forgetting a word isn't the file being deleted, it's the system taking longer to access it because its resources are tied up elsewhere. Losing a train of thought isn't the processor failing, it's the system lagging under a heavy cognitive load. This is a profoundly hopeful way to understand these changes. It means the brain isn't necessarily broken, just as the computer isn't ready for the junkyard. It's a signal that the system is overloaded. It's an urgent request to find and close that hidden program that's draining all the resources. But the medical system, focused on the most obvious problem, often does the opposite. Instead of closing the background program, it asks the already struggling computer to run the most demanding software imaginable. For Eleanor, her brain was already lagging, running on minimal resources when she arrived at the hospital. But then came the fall, the pain, the anesthesia, and the trauma of major surgery. This wasn't just another program running in the background. This was a forced shutdown and a full system reboot under the most stressful conditions possible. And when her brain tried to come back online with its RAM already depleted, the result was a catastrophic crash. The night after her hip surgery, the call Mark had been dreading, without even knowing what it was he was dreading, finally came. It was just after midnight. A nurse, her voice professional but strained, was on the line. Henderson, I'm calling about your mother, Eleanor. She's become very agitated. She's pulling at her IV line and shouting that she's trapped. We think it would be best if you could come down. Mark drove to the hospital in a cold sweat, his mind racing. Agitated? Trapped? It didn't make any sense. This was Eleanor, his rock, the woman who faced every challenge with a quiet, unshakable pragmatism. When he walked into her room, the person in the bed was not his mother. Her eyes were wide with a terror he had never seen before, darting around the room, focusing on things that weren't there. She was straining against the soft restraints on her wrists, her breath coming in ragged gasps. He rushed to her side, took her hand. Mom, it's me, it's Mark. You're okay, you're in the hospital. She recoiled from his touch, her eyes locking on his but looking right through him. Who are you? She whispered, her voice hoarse with fear. Get him off me! Can't you see them? Get him off! She was staring at the blank white wall, her body trembling. The spiders, they're everywhere. This was it, The catastrophic system crash. This was full-blown hyperactive delirium. The surgery had been a success. The bone was pinned, the mechanical problem solved. But the anesthesia, the potent pain medications, the trauma of the operation itself, they were the final, overwhelming push on a brain that was already at its breaking point. The slide into this terrifying reality hadn't started in the operating room. It had begun weeks ago in the quiet of her own home, with the anxiety over a phantom missing bill and the long, sleepless nights she dismissed as nothing. The hospital didn't cause the delirium. It simply and brutally revealed the profound vulnerability that was already there, hidden just beneath the surface. The Delirium Shadow had finally given way to the full-blown storm, and Mark was now standing in the wreckage, looking at a stranger who wore his mother's face. This is the moment that every child, every partner, every caregiver fears, seeing the person they love most in the world become lost in a terrifying reality they can't escape. It's a scene that is tragically, avoidably common. If this story, Eleanor's story, is resonating with you, or if any part of it feels painfully familiar from your own life, I'd ask you to take a moment and just press the like button below. It's a small gesture, but in the world of online information, it has a profound effect. That simple click is a signal. It tells the system that this conversation is important, helping this video find its way to other families who might be standing exactly where Mark was, feeling that cold flicker of unease, but not knowing what it means or what to do next. It's also a direct line back to me. It lets me know that we're on the right track, that this content is providing genuine value and clarity on subjects that are often shrouded in fear and confusion. This channel exists to serve this community, and your feedback is the most important guide I have. Now, that terrifying moment in Eleanor's room, her vision of spiders on the wall, represents the complete breakdown of the brain's ability to interpret reality. But that breakdown doesn't happen all at once. It's the final act of a process that starts with much quieter, subtler cracks in sensory perception. And that brings us to that third sign I promised we would cover, the one that is so often missed because it hides in plain sight. It's a change in sensory processing. The brain's filter for the outside world begins to fray. This can go one of two ways. The first is hypersensitivity. Suddenly, the lights seem far too bright. The sound from the television feels painfully loud. They might be more easily startled by a closing door or a ringing phone. It's an overreaction to normal stimuli, and we often just write it off as them being grumpy or tired. But the second path is more alarming, and it's a critical red flag, the emergence of misperceptions. This isn't full-blown hallucinations yet, it's more subtle. It's catching a glimpse of a shadow moving in their peripheral vision. It's mistaking the pattern on the wallpaper for a face, just for a second. It's asking, "Did you hear that?" when there was only the low hum of the refrigerator. They might not even be convinced of what they saw or heard, often dismissing it themselves by saying, "Oh, my eyes must be playing tricks on me." But it's not their eyes. It's their brain, laboring under that heavy metabolic load, struggling to correctly interpret the raw data its senses are providing. In an older person, this is a classic signal of a physiological one. And when you see just how frequently this critical signal is misunderstood in an emergency room, the numbers are genuinely shocking. Here's the problem. We are hardwired to associate hallucinations with severe psychiatric illness. When someone says they are seeing spiders on the wall, our cultural and medical training immediately points us toward a crisis of the mind, schizophrenia, psychosis, or severe dementia. We categorize it as a mental health problem. But in an older person, that assumption can be a catastrophic mistake. There is a fundamental rule in geriatrics that is not as widely known as it should be. New onset visual hallucinations are delirium until proven otherwise. It should be treated as a medical emergency, not a psychiatric one. It's a signal that the body is in crisis, and the brain is the organ sounding the alarm. And the failure to recognize this is not a rare occurrence. A study published in the Journal of the American Geriatric Society revealed a genuinely shocking statistic. It found that nearly 1 in 3 older patients who presented to the emergency room with delirium had psychotic symptoms like hallucinations. Let's make that number real. Picture yourself in a bustling emergency room. For every 3 older adults who were brought in suffering from delirium, one of them isn't just confused or agitated. They are actively seeing, hearing, or believing things that aren't real. And because that symptom is so dramatic and frightening, it often hijacks the entire diagnostic process. It sends the medical team down a completely different and often dangerous path. Instead of looking for the simple, treatable physical causes, the silent UTI, the dehydration, the medication side effect, the focus shifts to controlling the behavior. The response becomes a psychiatric consultation, or worse, the immediate use of powerful antipsychotic medications, which in a vulnerable brain can pour fuel on the fire and deepen the delirium. This misinterpretation happens because we are looking at the final terrifying symptom, not the root cause. The question we should be asking isn't, why is my mother seeing spiders? The real question, the one that leads to the correct diagnosis and treatment, is what physical stress has become so overwhelming that it has caused her brain's entire sensory system to short circuit. When the brain is operating under severe metabolic stress, its ability to correctly interpret the world begins to fail. It's not a failure of character or sanity, it's a failure of processing. The brain's intricate filtering system, which normally sifts through billions of bits of sensory data every second to create a stable reality, becomes overwhelmed and starts to glitch. The result is that the brain starts to fill in the gaps with its own distorted information. The shadow cast by a coat hanging on the door is no longer just a shadow. For a fleeting moment, the brain misinterprets it as a person standing in the corner. The low, steady hum of the refrigerator is no longer background noise. It's momentarily processed as a whispering voice. If a loved one mentions something like this, even in passing, and dismisses it with a nervous laugh, that is the moment to pay extremely close attention. It should be treated as a major red flag. This isn't their mind going in the way we fear. This is their brain sending out a desperate SOS signal that it is in a state of crisis. It's a physiological alarm, as clear and urgent as a smoke detector at midnight. And the appropriate response isn't to think about psychiatry, it's to think about physiology. This is the moment to immediately consider the most common physical triggers. Is there a urinary tract infection? Have they been drinking enough water? Has a new medication been started or an old one changed? The misperception is the symptom. The cause is almost always physical. And this crisis inside the brain doesn't happen in a vacuum. It is often preceded by equally subtle and equally overlooked changes in the body itself. And that brings us to the fourth sign of the delirium shadow, which moves from the internal world of the mind to the external world of the body. And this is a sensitive area because it touches on one of our deepest fears, the fear of physical decline and the loss of independence. It's profoundly difficult to watch someone you love, someone who was once so strong and capable, become physically frail. We often see it as the final, irreversible stage of aging, a one-way street we can do nothing about. But what if some of those physical changes aren't the end of the story, but are instead a warning sign of a treatable underlying problem? The signs we're looking for are specific and represent a change from the person's baseline. First, look for new unsteadiness on their feet. This isn't just a general slowing down. It's a new hesitancy in their walk. You might see them reaching for furniture for support in a room they've navigated for 50 years. A person who was walking confidently a month ago and is now suddenly shuffling or seeming fearful of taking a step is sending a powerful signal. Second, a sudden decrease in appetite or signs of dehydration. They might complain that food has no taste or feel full after only a few bites. You might notice their mouth seems dry or that their urine is darker and more concentrated. These are not just minor discomforts, they are signs that the body's basic regulatory systems, which are controlled by the brain, are starting to falter. A brain under stress from a silent infection or a metabolic imbalance struggles to manage the complex symphony of signals required for balance, thirst, and appetite. Frailty and delirium are deeply intertwined. A person's sudden physical vulnerability is often a direct reflection of their brain's internal vulnerability. So when you see these signs, try to resist the pull of despair that says this is just the end. Instead, see it as an urgent, actionable piece of data. The unsteadiness isn't just old Abe happening overnight. It is their body telling you their brain is in trouble. This recognition is critical because the very natural and understandable fear that arises from this new instability can lead to a behavioral change that makes the situation even more dangerous. And here we arrive at one of the cruelest ironies in geriatric medicine, a trap baited with good intentions and sprung by fear. When a person like Eleanor begins to feel unsteady, the world shrinks. The walk to the mailbox feels like a tightrope. The familiar path to the kitchen becomes a minefield of potential hazards. The rational, logical response to this new, terrifying feeling of instability is to reduce the risk. And the simplest way to reduce the risk of falling is to move less. So they choose the armchair over the walk in the garden. They ask for help reaching something on a high shelf instead of getting it themselves. They begin to conserve their movements, thinking they are conserving their safety. It is a completely understandable act of self-preservation. But this is the paradox. That very act of self-protection becomes a primary ingredient in the recipe for disaster. Immobility, even for a short period, is one of the single biggest, most well-documented risk factors for developing delirium once a person is hospitalized. The very thing they do to protect themselves from one crisis, a fall, inadvertently and dramatically increases their vulnerability to another, far more insidious one. It's another vicious cycle. The fear of falling leads to reduced mobility. The reduced mobility leads to muscle deconditioning and a loss of confidence, which in turn makes them even more unsteady. This downward spiral of frailty doesn't just weaken the body, it isolates the brain. It reduces sensory input, disrupts normal rhythms, and erodes the physical resilience needed to withstand the shock of a hospital stay. The fortress they build around themselves to prevent a fall becomes the very prison that ensures a more profound collapse of the mind. This self-perpetuating cycle of fear and frailty can feel unbreakable, like a trap with no exit. But what if the most powerful intervention to break this cycle isn't a prescription or a complex therapy? What if the solution has been hiding in plain sight all along, powerful precisely because of its simplicity? The most powerful intervention for breaking this cycle, for pushing back against the delirium shadow, is not a medication. It is not a high-tech brain scan or a complex surgical procedure. Bar none, the most potent evidence-based preventative medicine against delirium is a glass of water and a short walk. It sounds almost insultingly simple in the face of such a devastating condition, but the physiology is undeniable. When a vulnerable brain is dehydrated, its chemical balance is thrown off. Toxins and medications become more concentrated, placing an immense strain on the system. When a body is immobile, the brain is starved of the sensory input and oxygen-rich blood flow it needs to stay oriented and healthy. Hydration and mobility are the foundational pillars of cognitive resilience. They are the act of refilling the brain's depleted reserves, of widening that buffer at the vulnerability threshold. This isn't just a hopeful theory, it has been proven on a massive scale. A landmark program called the Hospital Elder Life Program, or HELP, was designed around these simple, non-pharmacological principles. The program uses a team, often of trained volunteers, to focus on 6 key areas: orienting the patient, ensuring they have their glasses and hearing aids, promoting sleep, encouraging mobility, preventing dehydration, and ensuring proper nutrition. It is high touch, not high tech. And the results, published in the New England Journal of Medicine, were staggering. This simple, human-centered approach cut the incidence of delirium in hospitalized older adults by an incredible 40%. 40%. A number that pharmaceutical companies would spend billions to achieve with a new drug. Yet here it is, achieved with a glass of water, a helping hand to walk to the window, and a conversation to keep the mind engaged. This is where your power as an advocate is at its absolute peak. Because this prevention doesn't have to wait for a hospital program. It starts at home, long before a crisis ever hits. If you notice these physical signs of frailty and unsteadiness, you can shift your focus. It becomes less about managing decline and more about actively building resilience. It's about making sure a full water bottle is always within reach. It's about reframing a walk to the mailbox not as a risk, but as a vital dose of medicine for the brain. It's about focusing on small, nutrient-dense meals to combat a waning appetite. Each of these small actions is a deposit into their cognitive bank account, building the reserve they will desperately need if and when they face the stress of an illness or a hospital stay. You are, in a very real sense, building a shield. But all of this incredible, proactive work, all of this careful shield building can be undone in an instant. It can be shattered by a single well-intentioned decision made by a doctor trying to help. And that brings us to our 5th and final sign, the one that reveals how the healthcare system itself can inadvertently become the primary trigger for the very crisis we are trying so hard to prevent. The 5th sign of the delirium shadow is a new or increased sensitivity to medications. It's perhaps the most quietly consequential of them all because it directly implicates the very system we trust to heal us. This isn't a dramatic allergic reaction. It's subtle. It's a slight increase in drowsiness after taking a pill. It's a bit more fogginess in the morning. A loved one might say, "That new pill the doctor gave me makes me feel strange." What they are often reacting to are drugs with anticholinergic properties. That's a technical term for a very common class of medication that blocks a key neurotransmitter in the brain. The list is long, and it includes some of the most common prescriptions and even over-the-counter drugs given to older adults. We're talking about certain medications for bladder control, medications for vertigo, and even something as seemingly harmless as Benadryl, which is found in countless nighttime cold remedies and sleep aids. In a younger person, these drugs are usually tolerated just fine. But in a brain already hovering at its vulnerability threshold, they act like a chemical fog, slowing down processing and creating confusion. They are notorious, well-documented triggers for delirium. And this creates an almost perfect trap. A physician sees one of the early signs we've already discussed, like anxiety or insomnia, and reaches for their prescription pad to offer relief. But in trying to treat the symptom, they can inadvertently prescribe the very drug that ignites the full-blown cascade. This is the prescribing catch-22 at the heart of the delirium crisis. Here is the paradox that makes this situation so tragically common. A doctor, seeing one of the earliest signs of the delirium shadow, like Eleanor's profound anxiety or her sleepless nights, naturally wants to provide relief. The patient is suffering, and the medical toolkit has a standard protocol-driven solution for that suffering. To treat the escalating anxiety, a common benzodiazepine like lorazepam, better known as Ativan, might be prescribed for short-term use. To combat the persistent insomnia, a powerful sleeping aid like Zolpidem or Ambien is a frequent choice. These are effective evidence-based treatments for those specific symptoms, and in a younger, more resilient person, they are often perfectly appropriate. But in a brain already hovering at its vulnerability threshold, these medications are not a gentle balm. They are rocket fuel for delirium. They act like a chemical sledgehammer on a central nervous system that is already struggling to maintain its balance. They don't just calm the brain, they suppress it, pushing it over the edge from a state of quiet, manageable stress into full-blown cognitive failure. The well-intentioned, entirely logical act of prescribing a pill to help someone rest becomes the very trigger that shatters their reality. It's crucial to understand this is not malicious. It is almost never the fault of a single bad doctor. It is a systemic flaw, a blind spot in a healthcare model that has become increasingly fragmented. The primary care physician sees anxiety and treats it. The cardiologist sees a heart rhythm issue and treats it. The urologist sees an overactive bladder and treats it, often with one of those anticholinergic drugs we mentioned. Each specialist, operating correctly within their silo of expertise, is focused on fixing the problem in front of them. But there is often no one in the room designated as the guardian of the whole. No one is stepping back to ask the most important question: what is the cumulative load of these interventions on this specific person's vulnerable brain? Our system excels at treating organs in isolation, but it often fails to protect the fragile, interconnected ecosystem that is the whole person. It's a system far better at reacting to individual crises than it is at seeing the quiet, predictable pattern that connects them all. I have seen this exact prescribing cascade play out with life-altering consequences more times than I can count. I could easily spend the next 10 minutes telling you another story. I could describe the 87-year-old retired school teacher whose family watched him descend into a terrifying paranoid delirium after being given a common bladder medication. I could detail the frantic calls, the antipsychotic drugs used to control his agitation, and the quiet, vacant man he became, even after the initial confusion cleared. I have a dozen such stories, each one a small, personal tragedy set in motion by a single well-intentioned pill. But I'm not going to tell you that story. To reduce this to one more anecdote would be a disservice to the scale of the problem. Because the individual stories, as painful as they are, aren't the real point. The point is the pattern they reveal. These are not isolated, unpredictable accidents. They are the logical, almost inevitable outcomes of a medical system with a profound and dangerous bias. Our system is structured for addition, not subtraction. It is far easier to add a new prescription to a list than it is to conduct the careful, time-consuming work of deprescribing, of asking, is this medication still necessary? Is it doing more harm than good through the longevity lens? Our system is built for reaction, not prevention. It is magnificent at responding to a crisis once it has exploded, but it is often blind to the subtle, preventative actions that could have stopped the explosion from ever happening. This pattern, this relentless momentum toward more intervention, can feel like an unstoppable force. But it's not. It's a series of decisions. And you have the power to influence those decisions. You can be the one who pauses the momentum. You can be the one who stands up and says, wait, let's look at the whole person, not just the symptom. You can break that pattern. So what do? You don't have to challenge the doctor's authority. You just have to change the focus. You oversee the point at which they become susceptible. And now I'm going to give you the exact tools to do it. So how do you do it? How do you step into that role? You do it not with demands or confrontation, but with focused, intelligent questions that shift the entire conversation. At the beginning of this video, I promised you a toolkit. This is it. I'm going to give you 5 specific questions to ask. Think of this as your delirium prevention toolkit. I want you to write them down, put them in the Notes app on your phone, and have them ready. These questions are designed to be used in any setting, with a primary care doctor during a routine visit, with a triage nurse in a busy emergency room, or with a hospitalist doing their morning rounds. Each question is carefully calibrated. It's not just about getting an answer. It's about signaling to the medical team that you are informed, that you understand the risks, and that you want to be a proactive partner in preventing a devastating outcome. They are designed to shift the focus away from simply reacting to symptoms and toward the collaborative, preventative care that can change everything. Let's walk through them, one by one. The first question is designed to be asked as early as possible, ideally upon admission to the hospital or even in the emergency room. Question 1. Given my mother's age and her recent changes in sleep and anxiety, what is our plan to proactively prevent delirium during this stay? This question does 3 things at once. First, it uses the clinical term delirium, immediately signaling that you are not just a worried family member, but an informed one. Second, it frames the issue proactively, shifting the focus from reaction to prevention. And third, by saying our plan, it establishes a collaborative tone.
You are not making a demand.
You're inviting the medical team to partner with you in achieving a shared goal, a safe hospital stay with a good outcome. This one question reframes your entire role from passive observer to active participant in care. The second question drills down on the most common trigger. Could we please review her complete medication list, including over-the-counter drugs, specifically looking for anything that might increase delirium risk, like anticholinergics or benzodiazepines? This question prompts a medication review, not just for drug interactions, but through the specific longevity lens of delirium risk. You're naming the specific classes of drugs, anticholinergics and benzodiazepines, that are known culprits. This shows you've done your homework and encourages the physician to look beyond the primary reason a drug was prescribed and consider its potential cognitive side effects. It's a gentle but firm request to apply a geriatric perspective to the pharmacy, which is one of the most powerful preventative steps you can take. The third question focuses on those simple, non-pharmacological interventions we discussed, the ones proven by the HELP program. Question 3. How can we as a team make sure she stays hydrated and as mobile as is safely possible, even with her current condition? This question moves the conversation away from what can be done to her and toward what can be done for her. It reinforces the importance of the basics. It also acknowledges the reality of her medical condition, as is safely possible, while refusing to let it be an excuse for immobility and dehydration. Again, the phrase "as a team" positions you as a helpful resource, someone who can encourage drinking water or assist with a short walk down the hall if the staff is busy. It focuses on simple, powerful interventions that protect the brain. The fourth question addresses the delicate and dangerous paradox of pain management. Question 4. What is the protocol for managing her pain in a way that minimizes the use of opioids or other sedating medications that could worsen confusion? Unmanaged pain is a major trigger for delirium, but the drugs often used to treat it, especially opioids, are also major triggers. This creates a difficult balancing act. This question shows that you understand this paradox. It doesn't demand no opioids, which can be unrealistic and dangerous. Instead, it asks for a thoughtful, nuanced plan. It opens the door to a conversation about alternatives, like non-opioid pain relievers, regional nerve blocks, or non-pharmacological approaches like ice or repositioning. It's a request for skillful pain management, not just sedation. Finally, the fifth and perhaps simplest question, but one that is so often forgotten in the rush of acute care. Question 5. Can we make a note in her chart to ensure her hearing aids are in and working and that her glasses are always within reach? Sensory deprivation is a massive trigger for delirium. When a person can't hear clearly or see properly, their brain is cut off from the orienting information it needs to make sense of a strange environment. They become isolated in a confusing sensory fog. This simple, practical step is one of the easiest and most effective ways to keep a person connected to reality. Ensuring this is noted in the chart makes it a part of the official care plan, not just a hopeful request. It's a small detail with profound consequences for maintaining cognitive clarity. These 5 questions are your script. They are your way of changing the narrative from one of passive acceptance to one of active partnership. And the response you get when you ask them will tell you everything you need to know about the quality of care your loved one is about to receive. A good physician, a great physician, will welcome these questions. They will lean in. They won't see you as a challenge to their authority. They will see you as a vital partner, an expert on the patient they've only just met. They'll recognize that you are providing them with the most crucial piece of data they can get, the baseline. They will see you as a second set of eyes and ears, dedicated to the same goal they are, getting your loved one through this crisis safely and with their quality of life intact. Your preparation will be seen as an asset, not an obstacle. But if you get a different response, you need to recognize it for what it is. If a doctor dismisses your concerns, if they wave their hand and say, "Oh, a little confusion is normal for her age," or if they seem annoyed that you're asking so many questions, that is a major red flag. Now, this doesn't automatically mean they are a bad doctor, but it is a strong signal that they may not be attuned to the specific, nuanced risks of geriatric care. It may mean that they are operating from a playbook designed for a younger, more resilient patient. In that moment, you have a right and a responsibility to escalate your concerns. You have the right to politely but firmly ask for a consultation with a hospital geriatrician or a palliative care specialist. These are the experts in navigating the complexities of the vulnerability threshold. This struggle, this need to advocate so fiercely, isn't just about one hospital stay. It's a reflection of a much deeper truth about the system itself. Eleanor's delirium did eventually resolve, but that clinical term doesn't begin to capture the quiet devastation left in its wake. It took weeks. Weeks of her being lost in a fog, of Mark sitting by her bedside, talking to a woman who wasn't quite his mother. And when the fog finally lifted, it revealed a changed landscape. She had lost ground, physically and cognitively, that she would never fully regain. The fierce independence that had defined her for 82 years was gone. The broken hip had healed, but the cascade that followed meant she could no longer live safely on her own. She had to move to an assisted living facility. Her story is a tragedy. But the tragedy is not that she fell and broke her hip. The tragedy is that she entered a system that was perfectly designed to fix the bone, but woefully unprepared to protect the person attached to it. The system saw a fracture to be pinned, a mechanical problem to be solved. It failed to see the fragile, vulnerable brain that was already sounding an alarm it didn't know how to hear. This reveals a deep and uncomfortable truth about modern medicine. It excels at the dramatic rescue. It is a marvel of science and skill when it comes to the heart attack, the major trauma, the emergency surgery. We are masters of the crisis intervention, but true health, true quality of life, especially as we age, is rarely found in the drama of the rescue. It is preserved in the quiet, preventative moments that happen long before the sirens ever sound. It is built in the steady, consistent work of building resilience. It is found in recognizing the subtle shifts in sleep and mood, in honoring that sacred vulnerability threshold, and in asking the right questions before the cascade ever has a chance to begin. This is the shift we must all make. We must learn to see health not as the absence of a catastrophic event, but as the presence of a deep, foundational resilience. It's about valuing the medicine that prevents the fall over the surgery that repairs the break. It's about understanding that a conversation about medication side effects can be more powerful than the medication itself. It's about recognizing that the true work of longevity isn't just about adding years to life, but ensuring that there is life and dignity and clarity in those years. This shift in perspective, from reactive repair to proactive resilience, is the entire foundation of this channel. If this approach to health, one based on evidence, driven by empowerment, and relentlessly focused on quality of life, resonates with you, then I invite you to subscribe to the channel. My promise to you is that we will never deal in simple answers or miracle cures. Instead, we will do the hard work of sifting through the evidence to find the practical wisdom that can genuinely change an outcome. Our goal here is not just to share information, but to build a community of informed advocates who feel capable and confident when they walk into a doctor's office. A community that understands the vulnerability threshold and knows how to protect it. By subscribing and clicking that notification bell, you ensure you won't miss our next deep dive. More importantly, you join a growing number of people who are choosing to replace helpless worry with focused, competent action. The knowledge we've discussed today is a powerful shield against a preventable crisis, but a shield is only as strong as the person who wields it. Now, I want to return to the question I asked at the very beginning of our time together. For those of you who shared your experience with a simple yes in the comments, thank you. By making your story visible, you helped erase the isolation that so often surrounds this crisis. You showed hundreds, perhaps thousands of others that they are not alone. And now, for everyone watching, I have a different, forward-looking question. After everything we have discussed, the Delirium Shadow, the vulnerability threshold, the 5 quiet signs, and the 5 empowering questions, what is the one single idea or tool from this video that you will carry with you? Was it the simple reframing of a conversation with a doctor, from describing symptoms to assessing risk? Was it the image of the brain as an overloaded computer, helping you see confusion as a sign of physiological stress, not failure? Or was it the profound, evidence-based power of a glass of water and a short walk? Share that one key takeaway in the comments below. Your answer won't just solidify the knowledge for yourself. It might be the exact insight, the precise turn of phrase that someone else scrolling through these comments needs to read today to feel prepared instead of powerless. Reading them helps us all learn. It helps us see the patterns. It transforms this from a video you watched into a resource we are all building together, turning shared experience into collective strength. After everything we've seen about the Delirium Shadow, what's the one conversation you now feel you must have with a loved one or their doctor? Answer in the comments below. I read and reply to every single one. In our next video, we expose the hidden pattern, a sudden memory blank that looks like dementia but could be caused by a common pill. Subscribe and turn on notifications so you don't miss the truth. Like this video and share it with someone who needs to know the difference.